Um, Last but certainly not least is our group that's going to talk through HIV and STI prevention. You've met Dr. Raphael Landovitz already from UCLA, but I'm going to now introduce Dr. Susan Buchbinder from the San Francisco Department of Public Health. And we had heard mention of you, Jean-Michel Molina from Paris, France, but here you are in the flesh, and it's good to have you with us. And so those are our two additional panelists. The other panelists are people you know already. So over to you, Rafi, and looking forward to this discussion.
No, thanks, Raj, and thanks everyone for sticking around. It's always a precarious position to be this late in the afternoon, so we really appreciate everyone's ongoing participation. Really an honor to be presenting on behalf of the prevention group here, who's tried to be thoughtful and forward-looking, really with the governing idea of if your friends and colleagues called you with these sorts of clinical conundrums, what would you recommend to them? So I know that's been our lens for all of this, but just want to reiterate that here. So these are my disclosures. And we're going to begin with a case as we have been throughout the afternoon. So this is a 19-year-old transgender female who presented to your clinic after struggling with adherence to daily oral TDF FTC for PrEP. She's seen advertisements all over her community for long-acting injectable PrEP, and she's interested in learning more about it. From a exposure standpoint, she had been diagnosed with secondary syphilis as well as rectal gonorrhea in the past year. And she also has a past medical history that's notable for hidradenitis suppurativa, some reactive airways disease that was requiring about on average a course of corticosteroids per year and regular use of inhalers, but she'd actually never been intubated. She had undergone a lap chole, and her current medications include topical estrogen preparation, spironolactone, acid suppression with a proton pump inhibitor, and bupropion for mood disorder. She's allergic to sulfamacrolides and quinolones. All three of these lead to severe urticaria that includes involving the mucous membranes, not desquamating, so not frankly TEN or SJS, but a severe urticarial syndrome, as well as reactive airways disease exacerbations from all three of those antimicrobials. So, first question to the group. So what is the preferred way if you're going to initiate long-acting injectable cabotegravir for her in somebody with this sort of history? A, would you start injectable cab with a standard injection and then go to an injection 4 weeks later and then every 2 months thereafter, the standard injectable loading? Would you begin oral cab for about 4 weeks and then if it's well tolerated, go with the injections? Would you start oral cab for about 4 weeks and it's well tolerated, start injectable cab with a 1 week overlap between the pills and the injections? Or would you just put her on oral cab, short acting only, and forget injections entirely? Please vote. Okay, so interesting. Okay, so we've got some split decisions here. Seems like most people thought injections were going to be okay. And some people would go direct to injections. Some people thought that they would do a standard oral lead-in, and if it was well tolerated, go on to the injections, and only 16% answered with what I think is probably the best answer and what we are recommending in the guidelines going forward, which is to actually overlap an oral lead-in with injectable by about a week if you are using oral cab as a lead-in, and if you're not, to consider using a tenofovir-based oral 1 week overlap, or if you're transitioning from a tenofovir-based oral PrEP situation, you can overlap that as well. So just going over some of the newer recommendations that we'll get to some of the specific ones talked about in this case in just a second. Just want to remind people that CAB-LA for people of childbearing potential, we feel like there's now sufficient data that it's okay to use that product in that particular context of pregnancy and breastfeeding. Some other recommendations that don't actually come directly from this case, but adopting a serostatus neutral approach to reduce stigma rapid care linkage for people with HIV and people at risk of exposures who test negative, we thought is an important new recommendation. Whoops, sorry. And with regard to injectable PrEP, there are some new recommendations. And the first is one that is referenced in the answers to the case that we just discussed, overlapping the first injection with oral PrEP if they are coming from a tenofovir-based regimen, or if you're using the oral lead-in to overlap by about a week. The other thing that I think is particularly interesting in this particular case is the strong atopic history. Of course, the oral lead-in is optional, but in this sort of situation with an extremely strong atopic history, Dr. Buchbinder, how do you approach this when you're thinking about whether or not you're going to use an oral lead-in before injectable CAB, which, per the guidelines and per the package insert is optional?
Yeah, well, I would think carefully about using an oral lead-in just because this patient has said that they don't do well on oral agents. So you want to get them onto an injectable as quickly as possible. But this is someone who has a history of pretty severe allergic reactions and atopy. And so I think this is someone in whom oral CAB is a reasonable approach. It's helpful that after that you have this overlap, because that does mean that you're starting injectable CAB earlier. But I think that it's because of this patient's medical history. It's a pretty rare situation that I would suggest that we go to an oral agent first.
Yeah, thanks, Susan. I think that's a really important point. We know from the clinical trials that there were HIV acquisition events that happened during the oral lead-in period, which of course in the randomized clinical trials was obligated. I think that really gets to something that we all in our practices know intrinsically, which is what you just enunciated so clearly and much more eloquently than I did, which is someone who is going to do better on an injectable product is already demonstrated challenges with an oral product. They're not going to do well if you ask them to take more oral product. So ordinarily, completely agree. But the atopic history, particularly of a severe nature, remember, once you give the injectable product, you can't dialyze it off, you can't excise the intramuscular depot, and you're married to it for prolonged periods of time. So that was why that was that recommendation. The rationale for the overlap is this observation that this is now based on published pharmacokinetic data. We believe that the time to maximal protection when starting injectable product, you get to these non-human primate correlate protective concentrations by 95% of people will be there by 5 to 7 days after that first injection. So that's the rationale for the overlap of something with broad protective efficacy. Jean-Michel, anything else that you would highlight in this particular case?
Thank you, Raphael. No, I think it's reasonable to switch this person to cabotegravir. I think the new recommendation is quite important because we don't really know the time to protection with cabotegravir injectable, long-acting. So I think it's safe now to think about this overlap with oral PrEP, whether it's CAB or TDF-FTC or TAF-FTC. And I think, according to the PK of CAB-LA, when it's injectable, it seems that it takes at least a week to reach high enough levels in plasma. So I think that's how the recommendation is based on these PK data.
Yeah,
I think Rafi,
yes, Carlos, please go ahead.
This is one that, as Susan, you and Jean-Michel have said, this is one that really would really important to talk to the patient, explain to the patient all this nuances, and saying, look, we're going to get you to a much better place, but we need your help for a week. Make an effort to take this medication. So I know you're having trouble adhering, but it really will be important so we can transition you to a much, something that is going to be much more acceptable and effective, and have that discussion, because it's asking for a little effort to get there.
Carlos, I think that's a really good point, right? The rationale for doing this is not to be punitive, it's to be safe. right? And so the investment for being able to be on a long-acting injectable is, to err on the side of caution with the short-acting version of the same chemical compound, so that if there were, an urticarial reaction that had the potential of progressing to, a toxic epidermal necrolysis or a Stevens-Johnson type reaction, or the reactive airways were to flare, in a severe way, you can easily stop the oral product, and you're not left with this prolonged pharmacokinetic tail that would lead to ongoing exposure.
Yeah.
Great. And any last comments about that before we move on? I just want to make sure we have time to get to everything. But I do want to be clear, right? This isn't in the package insert. We're the first guideline to recommend this. So you won't find this anywhere else. But we are, again, looking at the newest data, the pharmacokinetics, and giving the best clinical recommendation that we can, if someone were to call us up and say, what would you do? So I hope that makes sense to people. Okay, so we're going to continue that same patient. So the patient began oral CAB 30 milligrams a day, tolerated it well without any signs or symptoms of an allergic reaction, urticaria, or any reactive airways disease exacerbation. And after 3 weeks of oral dosing, you start cabotegravir LA and nothing untoward happens. She has a little bit of injection site discomfort that resolves after 48 to 72 hours with each injection. And you all have been diligently following the CDC 2021 and FDA guidelines for monitoring for HIV infection breakthrough on long-acting injectable cabotegravir using both a laboratory-based antigen antibody test, 4th or 5th generation, and an RNA test, a viral load test, before starting CAB and at the time of each injection. Fast forward, it's now the 7th injection. All previous injections have been administered on time, and the injection goes as planned, but the HIV testing algorithm has some interesting results. So the 4th generation antigen antibody test comes back negative, and the HIV RNA test with a lower limit of quantification of 20 comes back detected at 32 copies per milliliter. What is the correct interpretation of these results? Is it HIV acquisition in the early stages of infection? Is it a false positive result? Is it likely HIV-2? Or is it unclear what the status is and you need additional testing? Please vote. Okay, great. So 61% of people are giving the answer that I think is probably the best answer here, which is it remains unclear and you need additional testing. Mike Saag, how do you think about this when you get a low detectable RNA in somebody who's on CAB-LA and everything's been on time?
Yeah, it's a conundrum because the first thought I have is that HIV RNA level accurate? Is it true positive? And then you have to do the additional testing. I would not immediately jump to the conclusion that this is what you're going to talk about, I'm sure, is the Levi syndrome where there's low level detectable virus. It could be that, but it creates a mess, and it makes me wonder why we're doing PCR testing in the first place.
So funny you should say that. Many of you have asked, why are we doing this in the first place, just as Dr. Saag alluded to. And the answer to why we were doing it is, if you remember in HPTN 083, one of the registrational trials that led to the FDA and other regulatory approvals of cabotegravir, there was this observation that on stored retrospective samples, you could find evidence of HIV infection long before the antibody and antigen-based test detected it, and often before integrase resistance developed. And it was on the basis of that observation that this recommendation got into the package insert in the US and in Europe, as well as in the CDC guidelines in 2021. We presented some data from 083 in Munich this past summer that shows that its positive predictive value, an RNA as a positive test by itself, is terrible. It's 9% in this clinical context, which basically means 9 out of every 10 times you get this result, it's a false positive. And that, of course, has clinical consequences, delayed injections, incredible out of emotional distress for both the patient and the provider, and all sorts of confusion. So for that reason, we are recommending something that you won't see in any other guideline yet. But I know a lot of other guideline groups are thinking about this. So we are recommending that for follow-up on CAB-LA PrEP, instead of an RNA test, what is done is a rapid test at the time of the injection, and also a laboratory-based antigen antibody test that is sent but not resulted before you give that injection. And we still think it makes sense to do an RNA test before you start CAB. But if that's not available before you start, to repeat an antigen antibody test a month after starting any kind of PrEP, just to make sure that you weren't in that super early stage of acute or eclipse infection, and then are liable to be repeatedly or prolongedly exposing somebody to a not completely suppressive ART regimen, which of course could increase the chance of selecting for resistance-associated mutations. So I hope that makes sense to people. Happy to go over the data or send people the slides of the presentations that support that. I didn't want to spend a lot of time today, getting down and dirty in the clinical data that supports it. But this is a big sea change from what is in the current CDC guidelines for the moment, and the current FDA package insert in the United States and Europe. So wanted to make sure that that was highlighted.
So Rafi, just an additional thing. I mean, this is incredibly complicated, as you and I know. I think the other issue is that many of these acute infections occur right at the time you're starting therapy, right? Or at the time you're starting the drug. That's when we picked up a fair number of them. So that's a particularly vulnerable time when the person is starting therapy.
Right. Thanks, Carlos. I think it's a really important point. Remember that any delay in initiating PrEP, waiting test results, and somebody who has antecedently been HIV test negative is an opportunity for someone to be vulnerable to ongoing exposures, right? So for somebody who is likely to have ongoing or frequent exposures, there are almost no circumstances where it would be inappropriate, assuming there are no symptoms or signs consistent with acute or primary HIV infection, where you would not want to initiate PrEP and await testing and then intensify if you get a positive test result back. Now, if somebody comes in and you're within a 72-hour window of that exposure, the right thing to do, of course, is give a 3-drug PEP regimen and then seamlessly transition to PrEP. But absent that situation, right, you don't want someone to be left vulnerable while you're waiting for test results to return.
Absolutely.
Susan or Jean-Michel, anything that you would want to add or correct that I said about that?
No, I think you hit the nail on the head, and I do think that chasing after these these very low positive results is really fraught with problems.
Yeah, thank you. And so, I'm sure many of the people on this call who have used cabotegravir PrEP already are thinking, but this is our protocol. This is what we do. The CDC guidelines still say to do it. The FDA package insert still says to do it. So we're doing it. And now I get this result. What do I do? How do I disambiguate this low positive RNA result? And figure out, is it a false positive, or is this the first manifestation of, as Mike was alluding to, the Levi syndrome, early HIV infection with an atypical acute or primary pattern on the HIV testing? So let's interrogate that. So you counsel the patient that this is a very sensitive HIV test, looking at the genetic components of the HIV virus in the blood, and it's returned positive at a very low level. And out of an abundance of caution, those of you who know me know that's one of my favorite phrases on the planet. You want to be patient. You want the patient to come into the office as soon as possible to repeat the testing. And in the meantime, the better part of valor is to use condoms for any penetrative sexual activity, just given the uncertainty of the testing results. So you repeat that testing algorithm because you are a follower of the CDC guidelines and the FDA package insert, and everything comes back negative. So what does that mean? What is the correct interpretation of these results? The original result was a false positive. Follow-up testing confirms that there is no HIV infection. PrEP should be continued. Or the original results remain concerning, and a third round of testing using the same algorithm should be repeated in 2 weeks. Or the original results remain concerning. A third round of testing should be repeated, but this time include a DNA assay. Or these results actually confirm HIV infection. Please vote. Okay, so the majority of you got what I believe is the right answer here, which is this is a false positive test result. And that is, in fact, confirmed, by the negative testing. And again, the abstract that we presented in Munich that looked at this very poor positive predictive value of an isolated RNA test being positive also showed that you could discriminate true positives from false positives when the RNA test is the only thing that's positive on one testing result by just repeating it. If the RNA test is positive again at any level, including below the limit of quantification of the assay, or it's positive with any additional orthogonal tests, so either a rapid or an antigen antibody test, that is confirmatory that that first isolated RNA result is a true positive, and that person should be referred for fully suppressive ART. But in this case, everything was negative, and so you can continue PrEP without delay. I hope that makes sense. So our recommendation is don't do RNA testing except before you start and after a 6-month or longer hiatus if injections are delayed. But if you are doing it because you are a rule follower with the current FDA package insert, the way to disambiguate these results is to immediately retest, and that should give you the answer based on the data that we have at this time. Jean-Michel, anything that you'd like to add about that particular point?
No, I think it's already is a very difficult situation to handle for the physician and for the patient. And I agree that the way to try to understand what's going on is to repeat testing, like you said, RNA and the serologic assay. One of the issues that you've discussed in the case was that these patients should, resume the use of condoms. And I wonder whether, with a viral load of 32 copies, you think there is a risk that this person could transmit HIV if she was not using condoms.
Yeah, no, thanks, Sean. I think it's a really good point, right? I mean, we know now that there are no cases of HIV transmission through sexual routes, with viral loads less than 200, and it's vanishingly rare under 1,000, right? We now know those two things to be true, vis-a-vis U equals U. But because it was 32 now, right, we don't know if this actually is the first manifestation of what is going to be a burst of viremia. What's it going to be next week? So that's why I think it is reasonable to err on the side of caution with that recommendation. But you're right, with a viral load of 32, you would not expect ongoing sexual transmission. Whether or not there could be parenteral transmission if there's an injection drug use history reported that's ongoing is a different and unknown question, right? Okay. Super. So the next question for the group sort of piggybacks on that. We've sort of gone over this, but let's just see if people are still paying attention this late in the afternoon. Going forward, what is the recommended HIV testing algorithm to monitor for CAB PrEP failure? Rapid tests only, rapid tests and an RNA. That's a typo. It should be RDTs. Rapid diagnostic tests is what that stands for if you're not familiar. An antigen antibody and an RNA, or RDTs and an antigen antibody. Please vote. Okay, so we had sort of talked about this a little bit. We are recommending for monitoring of on-prep breakthrough, our recommendation is an RDT and a laboratory-based antigen antibody test, which is option D. The basis for that recommendation comes from data that from 083 and 084. I'm not going to belabor it because we have one more case to get to, and I want to get to it. Which is the positive predictive value of various combinations of these rapid tests and laboratory-based antigen antibody tests. And you can see that either two rapid tests or a rapid test and an antigen antibody test both performed well for positive predictive value across both studies. So that's why our recommendation is that those two tests should be performed for on-prep monitoring of long-acting PrEP agents. Okay, let me move to the last case because I want to make sure we have time to talk about this. This is a 24-year-old cisgender woman, sorry for the typo there, woman, who presents with a second case in the past 18 months of chlamydia and currently also has a genital painless ulcer and a newly reactive RPR of 1 to 128. So presumably an early syphilis diagnosis as well. You plan treatment of all the active infections and a discussion of HIV pre-exposure prophylaxis, as well as contraceptive planning. But she also asks you about this intervention she's heard about from her gay friends called doxy-PEP. What is your recommended guidance for the use of doxycycline for bacterial STI prophylaxis for cisgender women? Option A, it's reasonable to prescribe for this patient with shared decision-making and acknowledgement that the data are not available to confirm efficacy. B, it would be strongly recommended as there are 3 randomized studies that support its use. And C, it is contraindicated in persons of childbearing potential, so don't do it. And D, rather than doxy-PEP post-exposure prophylaxis, doxy pre-exposure prophylaxis should be used. Please vote. Okay, so 78% of you said A, and I believe that that's the right answer also, and you might have noticed that was in your pre-test, so thanks for answering it correctly. I am going to actually shut up here and give the floor to the 2 people on our panel who were generators of some of the primary data that have evaluated the use of this technology to share their thoughts. So Dr. Buchbinder, do you want to lead us off?
Sure. So there was a randomized controlled trial in cisgender women that did not show efficacy. But we also know that adherence was quite poor in the study. And so it seems like it's parallel to some of the early PrEP studies where there was no efficacy seen, but it was because of poor adherence. The PK data suggests that it should work in women. It should work in the female genital tract. This is a woman who's at quite high risk, and it's been quite effective for syphilis and chlamydia in men who have sex with men and transgender women, with an efficacy in the 70 to 80+% level. And so I do think that it's reasonable to counsel the woman that we don't have efficacy data yet, but that she may benefit from it and do undergo sort of shared decision-making about decisions about whether or not she might start on doxy-PEP.
Thanks, Susan. Jean-Michel, anything that you would add?
No, well, I agree with Susan. And, you know, there has been at Munich earlier this year a short presentation of the use of doxy-PEP in female sex workers, where they have seen interesting decline in syphilis and chlamydia over time. So it was not a randomized study, it was just an observational study. So this is another piece to suggest that there are reasons to think that this strategy could be also effective for women, but we don't have randomized trials available today, but there are ongoing studies to address this question right now.
Right. Thanks, Jean-Michel. That non-randomized study, I believe, was from Japanese investigators, if I remember correctly, from Croy, and that was actually doxy prep, though, wasn't it? Wasn't it
Yeah.
daily use?
Yeah.
Yes, you're right. There was
Yeah.
a doxy, daily doxy.
Right,
but
right. But still, it's sort of proof of concept that the drug is active in the female genital tract, right?
But
Exactly.
we may benefit from an LA doxycycline at this point, right?
We'll be sure to work on that right away. Yes, but as Jean-Michel pointed out, there are ongoing studies right now and additional studies planned to answer this in a rigorous randomized trial way to try and help definitively answer this question. So stay tuned for more about that. So that's a new recommendation that we wanted to put out there, that this is a reasonable thing to do. And additional new recommendations that I just wanted to highlight is when you're prescribing doxy PEP in general, we recommend that you prescribe 30 doses, that's 60 tablets or capsules at a time, to try and assure that people are going to come in for the regular STI screening quarterly or more frequently, depending on the rate of exposures and symptomatology of all the contact sites and blood syphilis testing. So that's our recommendation. Obviously, we have some data from the clinical trials about how it's been prescribed, and relatively little real world experience that informs that question. But certainly the evolving real world clinical experience from San Francisco and other locations is all suggestive that at a public health intervention level, this could be a really exciting intervention. We're, of course, still looking at the effects on the microbiome and on resistance, both in Staph aureus and other Neisseria species, to try and get a full picture of the potential impact and liabilities of this intervention. But there's no question it's a really exciting advance in the biomedical prevention of STIs. So my last slide was just the data that Dr. Buchbinder already referenced from the DPEP study in Kenya. It's in the New England Journal from Janelle Stewart. Please go find it. And I will stop there. Happy to take questions. Sorry for running a couple minutes over, and thanks for your attention.
Great, thank you, Rafi, and the entire prevention group. I'm going to go through a couple of questions that are still in the Q&A, and then a couple that have been answered online, but I wanted to explore in a little bit more detail. So going back to the RNA, as you said, this is probably one of the larger, bigger changes in the IAS-USA guidelines, and I anticipate might be followed by other guidelines bodies. But what about the height of the viral load? Rafi, maybe you can comment on this one. If it's 51 copies versus 500 or 550 copies versus 5,000 copies, does that make a difference in terms of false positives?
Yeah, thanks, Raj. It's a really important question, and we did look at that in the 083 data set. And I'll say two things about that. First is, in the clinical trials where this was being done prospectively, we had to come up with some clinical guidance for the trial participants, right? And what we implemented was any single viral load over 200 copies, doesn't matter what anything else was doing, we treated as someone to be referred for fully suppressive ART. Any two sequential RNAs detected at any level, even if they're both below the level of quantification, we also treated as someone to be referred for fully suppressive ART. Short of that, we continued PrEP and followed people. So when you look at the data now that we have the data set complete, that seems to be a reasonable discriminatory line of a single value above about 200. That is not a line in the sand that's definitive. There was one case that we had that was slightly below 200. That was a true positive. We had one that was slightly above 200. That was a false positive. So that is not perfect, but the higher the viral load on a single test, the more confident you're going to be. But the only way to 100% discriminate the two was just to repeat it.
Yeah, and I think that last point about this has been known for some time, that these RNA tests have false positives, and if you had if you have a viral load of 5,000, it's not a false positive. It's a true positive.
Unlikely to be. The highest viral load that we saw that was a false positive. And it's a really complicated case, and I'm sorry, I don't want to get into it. We believe it was actually a sample mix-up, so who knows what it means.
Of course.
3,000.
That's a fair point. False positives can be, as Davey Smith has put into the chat, some biologic false positivity because these are PCR-based tests, and some of it can be human error, can be cause of false positives. So.
And of course, that causes a tremendous amount of distress for everybody involved that, I can't even begin to quantify, right?
Can someone comment? We didn't go into much detail during the presentation, but we do have a section on lenacapavir, and this is coming. I think by the time we do this, 2 years, it will not only be here, but if we did this in 1 year, it would be here. Has this issue of RNA false positives, Levi, been seen with lenacapavir?
Yeah, it's a question that obviously I am particularly interested in, as are many others. You've got an incredibly small data set at this point, right? You've got an N of 2 incident HIV infections, both from Purpose 2. They both happened between the first and second injection. One was detected at week 13, one at week 26 on lenacapavir treatment in that Purpose 2 lenacapavir arm. There is no evidence in those 2 people of substantially delayed evolution of antigen or antibodies. One of them with a very high viral load, I believe it was like 900,000 or something like that, had a fully evolved antibody panel, rapids and antigen antibody, as well as nucleic acid tests on retrospective testing. And the other one had a negative rapid test. The viral load was about 14,000. The antigen antibody was positive. And one of those, on a very sensitive single copy assay, they were able to see evidence of RNA in the visit immediately prior. I believe it was the 13-week time point HIV acquisition. There was, I believe 6 copies of RNA detected at week 8. But that's the data set that we have so far. I don't know if that's going to hold true when we get more experience with it, or if perhaps is there a differential in the barrier to resistance of the drugs? And because of these very high viral loads and the resistance patterns, there was lenacapavir resistance seen in both of those quote unquote breakthrough infections. Is it, just a fully evolved infection and we're not going to see this delay? I think we do need to interrogate this with every new long-acting PrEP agent.
Yeah, in that regard, I was struck by how high those 2 viral loads were. The Purpose 2, just as a reminder, was in transgender people and men who have sex with men, as opposed to Purpose 1, which is in cisgender women where there were no HIV acquisitions, but they were pretty high. And I do think that lenacapavir is going to behave differently than cabotegravir in this regard, but time will tell. Let's go to doxypep, and maybe I'll ask Jean-Michel let me ask Susan first and then Jean-Michel. If you have a person who's taking doxypep 3 times a week, because of and taking 200 milligrams as recommended, but is taking it 3 times a week, would you think that they should take it daily, or should they take 100 milligrams daily? How would you advise someone who's taking doxypep 3 times a week? Maybe Susan, you Dr. Buchbinder first.
Yeah, I think Jean-Michel probably has some answer to this as well, but we don't really have great data on daily doxy. It has been tested. It has been studied in very small studies, not RCTs, not randomized controlled trials. So I would probably talk with the person, but generally I would leave them on 3 times a week, 200 milligrams an episode, because we don't really have the same database for doxy PrEP.
And Jean-Michel, you did one of the earliest of these doxy peptides. Why did you choose 200 milligrams? Why was that dose chosen?
Well, the dose was chosen because it was used in other settings for, prophylaxis for Lyme disease.
Lyme disease. Yeah, I was going to say, where I live, Lyme disease, it's all about Lyme. So.
Exactly. So, and other for leptospirosis as well. So that was the reason why the dose was chosen, and the reason why we used post-exposure was because we thought people would remember best after sex to use the drugs rather than before. And also because we wanted to reduce the exposure to antibiotics. And unlike, daily treatment, where you may, have a greater, antibiotic pressure, I think using it only when it's really needed, again, would reduce the overall use of antibiotics. And that's why, people, on average, actually, in the trials, they used the doxy, the 200 milligram dose, only once a week on average. Some people use more, other less. On average, it was only once a week. And I think it seems, one of the concerns with this strategy is really the, increase in antibiotic resistance. And clearly, if we could use just the amount needed to prevent these STI without having any harm on the antibiotic resistance, that would be better. So that's why, probably if people could use it not more than once a week on average, that probably you have maybe the right balance between benefits and harm.
Perfect. I have one other question, but before we leave, can you say what is the latest on antibiotic resistance with doxypep? What should the clinician know when their patient asks them about that right now?
Well, I think we have not all the answers today because
What
the
do we know
follow-up we have
today?
is quite limited at this point. As expected, when you use doxy for gonorrhea, for example, you will select strains with a higher level of resistance. This is like a given with gonorrhea. For chlamydia and syphilis, we haven't seen any resistance yet. And regarding
microbiome, Staph aureus, microbiome, what do we?
Well, I may let Susan to comment on that because the group has published on the topic of microbiome.
What to say to people about Staph aureus and other non-STIs?
Yeah, I think the question about off-target resistance is one that's very important. We are not seeing a tremendous amount of off-target resistance, but I think the data sets are still quite small. And so there's a much larger study that's launching soon that will take place in 5 US cities that will get us a lot more data on off-target resistance.
The last question, and then we'll transition to our concluding remarks. The size of the needle in a person who is obese, either for treatment or prevention with injectable therapy, can someone comment, is it really true that anyone who has a BMI over 30 is off the table for injection, or can we use a longer needle?
No, I think, the goal is to deliver the injectable product into the muscle. So I think there can be clinical judgment as to, where the person in front of you, the patient in front of you, carries their fat, right? Someone can have a BMI that's 30, but it's all central adiposity, and maybe there isn't a lot of gluteal fat. I think whatever needle someone who is experienced with intramuscular injections believes will deliver the injectable product into the muscle is the right needle to use.
And ask about the Brazilian butt lift.
That's right.
Generally ill-advised.
I've seen a little bit too many mycobacterial infections in recent weeks. So, all right, why don't we leave it there? I think this has been a tremendously enlightening and hopefully dynamic and compelling presentation of the guidelines. Please do give us feedback both on today's presentations, but also on the guidelines in JAMA. As I mentioned at the outset, they're available free of charge. Please take a look, send us your feedback, and I'm going to turn things over to Dr. Saag for the final word.